Thanks for taking the time. For those of you who don't know me, my name is Phil Englert. I'm the Vice President of Medical Device Security for Health-ISAC. I've been there for about 2 years, but I've been in this business, I counted them up a couple weeks ago, for like 37 years. Can you believe it? I can't. It's been a long time. And I've done a lot, but I started out fixing clinical lab analyzers for Fisher Scientific and instrumentation labs. You know, and if you know, you've all seen the Fisher Scientific catalog. It's about that thick, right? So they sent me to school for a week in Pittsburgh, taught me how to fix tissue processors, water baths, and incubators, handed me this catalog and said, go out and fix. And so anything, right? People would call me up, and I was in the Bay Area at the time. People would call me up, you know, and they'd be like, hey, come work on this. And I'd have to look it up in the book, you know, to see what it looked like. So I didn't walk past it the next day in the lab. And then I'd be like, hey, when you come in, what's the first thing that you do? And they'd reach back and hit it. I'm like, good, now I know how to turn it on, you know? And that's how I got my start. And I ended up managing a number of hospital biomed programs, you know, just kind of working up the ladder. Eventually they took away my toolbox, had me flying a desk, you know, doing well. I ended up at Catholic Health Initiatives, 100+ hospital. You guys know them now as Common Spirit, right? 130 something hospitals after they merged with Dignity Health. And then I retired from there, failed miserably at it, had a job the next day actually with an NGO, right? And then I've bounced around a few times before finally landing back here at in a non-for-profit world of Health-ISAC. So let's go in there, and you can see on the right, I've just been involved with a lot of stuff. First, when I got into cybersecurity, it was like, what is this all about? Because I was a clinical engineer. I didn't know what things were, you know? I didn't know what a IP address was or any of that stuff. So I had to learn it from the scratch, you know, and that's what we're all doing, right? But then I got involved in a lot of industry shaping things as well. So including like UL, Underwriters Lab, their ST2900 for cybersecurity force. And most recently, I'm with the ACC Board of Examiners. So really happy about that. Super pleased to be there. So Health-ISAC is a member-driven organization. Yeah, what is an ISAC? You guys, I told you I worked there. You're like, well, what is it? It's an information sharing and analysis system. It was created after a presidential decree creating critical infrastructure, right, for the United States. Critical infrastructure is defined as anything that, if it goes out, will cause civil disruption, right, civil unrest, and become a national security issue. So just think about the things that if it went away, you'd be like, what do we do, right? Telecom, transportation, energy, water, healthcare, nuclear. There's about 16 of them, I think, there's in here, and there's ISACs for all of them. Financial services, the auto ISAC, it's all there. Multi-state, retail and hospitality, right? So these are just, they're formed really to share information, security information across that sector that's specific to that sector, right? And it works. It really is amazing. And not only do we share InfoSec, we share tools, we share best practices, we share policies, we share just good information about what we do and how we get it done, because we're working with the doers, right? So it's a nonprofit, member-driven organization, yada, yada, yada. You guys don't need to know all that. 11,700 individuals. We say we have that many analysts working for you because they're all sharing threat intels, right? Who heard of Change Health, the big breach that happened there, right? Few people, hands go up, right? Change Health, right, processes a lot of back office stuff, right, for healthcare. Right? They do 137 different applications. There are hospitals that is their only processor. And when they shut down and disconnected, these people got no money, right? Their covered lives, over 100 million. That's 1/3 of the population. And they've been down for over a month, right? Where they're not connected. Big impact there. So we've got, but United Healthcare, right, the owning group, right, they shared their IOCs, their indicators of compromise with Health-ISAC. We put it out to everybody else. So then people could look in their systems and see whether they were getting attacked along the same vectors, right? Important stuff. And the ability to detect and respond to that immediately is so essential, right? So anybody in the healthcare sector, right, is in there. Pharmacy, biotech, life sciences, mortuaries, right? If you've got something to do with a patient ID, think of it that way, kind of rule of thumb, you're eligible for that. And I'm guarantee you that many of you in this room are members, and you just don't know it because we're working with your IT groups, right? So ask me, I'll tell you, we'd love to get more HTM folks involved in here, and this is what this talk is all about. So member demographics, we're working with a lot of them. Probably the most important thing on the side is the tier 1, 2s, and 3s. These are the smallest folks, right, in our membership, lowest revenues, right? And we've got more of them than anybody else. So what we really like to do is leverage the knowledge. I don't know if I have a laser here. Leverage the knowledge of the big boys to help the smallest folks there, right? Because that's where the resources are and that's where the resources lack, right? Very important. I can't tell you who members are. We kind of keep that private, but you can tell by the board of directors the kinds of organizations that are members, right? And we have close to 800 organizations worldwide, all of your favorites, all of the well-known ones. If they're big, they're playing here, and many of the smaller regional players as well. So we know healthcare is under attack, man. We get ransomed left and right. I was just down in Australia at an APAC summit, and I saw a statistic. It was pretty incredible, and they said ransomware attacks like in 1 month, and the United States had 114 healthcare, right? The next closest country was like France, and they had like 14, right? And after that, and it went down from there, right? So the next 8. So I think because we're willing to pay, we have the money, we are very much a target for this, right? But this happened years ago. It was just, where are we, Arizona, just west of us, right? Or we're in Las Vegas, yeah. So what week is this? But this was in Hollywood Presbyterian, right? A large urban trauma center in the heart of LA, serving, the underserved communities, in the LA area, right? And they got hit, right? And this came in like on a Word document, right? All of a sudden they couldn't access records, right? Declared an internal emergency, started emptying out their ICU, their ER went on divert, no more surgeries, they just were shut down, right? Patients were diverted, they called in law enforcement, right? They paid 40 Bitcoins. Doesn't seem like a lot. Even then it was only $17,000, right? And they paid that after 17 days, or after 10 days, I'm sorry. Recovery declared on February 15th, right? 10 days later. The thing was, they were losing $1.8 million a day in revenue. So this is big impact stuff, right? Big impact stuff, right? And it's just Lockieware, spread through MS Word, right? So the breach count by entity type, I think this is interesting. Let's see, I don't have a laser. Okay, maybe I do. There it is. So I think this is interesting. The yellow or the gold here is healthcare providers, and the blue are our business associates. And I bring this up because you can see that business associates are growing. Our dependency on other parties are big. It's a big thing, right? And if we go to the next slide, you can see that the number of records that healthcare is breaching continues to climb. That's not the thing, but look at the spike in our business associates. So as we become more dependent on partners, they become more susceptible, right? And interestingly enough, HHS is very much about victim bashing, right? They charge the hospital for this stuff, not the BAA, so it's tough. It's tough on us. And the reason I bring this up, because I was talking to a group just about that, Change Healthcare, and one of the things I said is, if this was a bank, the United States federal government would have stepped in about 2 hours and said, this is too big to fail, and pushed all kinds of money and resources at it. But because it was healthcare, we didn't recognize what the impact on the United States was going to be for a long time, and we've been very slow to respond, right? But as we become more dependent on digital platforms, as we push all of our digital images right up to the cloud, as all of our medical devices come off of the internal pacemaker, or the other sensors, and through our phone and up to the cloud before they're redistributed back down to our healthcare providers, This is going to be a concentration risk that we should be aware of and start thinking about, you know, as maintainers. Okay. So lots of stuff here. This is the thing, you know, cybersecurity attacks, 48% impact patient care, right? And what are some of the ways that patients can be impacted on this, right? I can't get services. They're not doing surgeries, right? What's the first thing you hear when Common Spirit, they got breached, right? $160 million it cost them, right? That breach, how did we find out about it? On the news. And who were they talking to? Common Spirit? No, they weren't saying anything. They're like, we got it under control. They talked to patients that were like, I'm all upset. They canceled my surgery and I have no idea when I'm going to be able to get back in there, right? Or, you know, I can't get a hold of my doctor. I can't get things scheduled. And then the nursing staff or the other clinical staff begin to say the same thing, right? So it's there. It's an impact. It's out there. So this happened in Germany, not directly in the United States, right? But they had a Russian group had ransomed the Dusseldorf University Hospital, impacted 100 servers. They had no way to talk to the ambulance. The ambulance service picked up a woman with a aneurysm, right? Aortic aneurysm, and they had to divert her, right? 32 kilometers, about 20 miles, right? And the patient died. And they're like, oh my God. And the funny thing was, this was a Russian-based hacker group, and they had no idea. They had no idea that they impacted patient care that way. And when they found out, they said, here's the key. They said, we didn't mean to do that. But just like your IT can't always tell that on the end of the wire, that Windows box is actually your control panel, your control station for your MR or your CT, neither can the hackers. They're no better at it than anybody else is, right? It just looks like a Windows box. So it's there. So this was the first negligent homicide investigation. And what they found out, and they didn't prosecute this group, because they determined that regardless of which facility the woman landed in, she would not have survived her instance, right? So kind of unfortunate, but it shows that healthcare gets impacted by this stuff, right? And it's that. So why is it so tough, right? Part of it is the diversity of equipment that we have, right? There's a ton of it, right? They're purpose built, right? And anybody, the definition of IoT, right? How is that different? The Internet of Things, right? Why is that different than IT? It's outside of IT, right? I like that gray area. That is a big gray area, right? So the thing is, the Internet of Things can interact with the environment, right? That's really the defining thing, right? They call it cyber physical devices now. Every 6 months they come up with a new name for it, right? So it can interact with the environment. So it can either sense the environment or act on the environment. And in healthcare, the environment is very often a patient. It's a person, somebody you know, somebody you care about. It's on there, right? They're also designed to be precise and reliable. And you guys are all, how many biomeds are in the room, right? So pretty good number, right? You guys have looked through the specs on your biomed stuff, right? On the medical equipment that you're buying. Will it operate like in Antarctica? Will it operate in Brazil? I mean, this stuff is just shy of mil spec. I'm telling you, it is designed to be highly precise and highly repeatable, which is exactly what we want from our medical devices. But what does that mean? It's not really flexible. Can't update it too easily, right? So it's a challenge there, right? We've got a lot of technology debt. I overheard somebody talking, I think it was you, right? 19-year-old system in your hospital, right? And you're like, that shouldn't be here. And I'm telling you, I had stuff that was 21 years old, and my radiologist was like, if I got to get on the table, that's the machine I want taking the picture, you know? So, right? So that's the thing, right? But we have technology debt, and a lot of stuff, I got enough white hair, a lot of this stuff was not connected when we started, right? Sterilizers, not connected, right? It was a pump system, right? OR lights, not connected. OR tables, not connected. Now your OR lights are the heart of your communications in your OR, right? So we've added all this technology capability to stuff that was never there, right? I mean, it used to be medical devices were wooded boxes with dials on it, you know, and we've come a long way. It's gotten a lot safer, you know. I mean, we used to do electrical safety on everything because what, right? X-ray machines had 420 volts on their tunable coils. If you were at a wet location, that could kill you, right? We're more digitized, lower voltage control stuff, right? But it's not as dangerous as it was, but it still has impacts, right? We have different modalities, and in a hospital, it's not just medical devices, right? You've got a lot of other stuff. How do you get patients from A to B, right? How do you move stuff, samples around the hospital, your tube systems, your communication systems, your radio systems, right? Now we're putting 5G on the roof so we don't have to run wire through walls with asbestos in them anymore, right? So it's just incredible, just incredible. A lot of other IoT modalities in there, right? The FDA has decided, and you guys can read on this, right? They've said, hey, we know this is a problem, right? And they're doing something about it. So if the FDA is finally paying attention, this is it. Now, the interesting thing about the FDA, right, they're what? Well, they're like the consumer safety group, right? And safety is the key word there, right? Because what they had was statutory authority to regulate for safety. But cybersecurity, interrelated, kind of that, who mentioned it, the gray space, right? The gray space. So it wasn't a direct correlation to safety. And so they knew it was important. They didn't have the regulatory authority for it, right? And here's the other thing, devices like this, another one, anesthesia machines, right? That's just an air pump, right? For gases, I shouldn't say air, it's gas pump, right? Very mechanical. Whoever thought that monitors would be a regulated device, right? But for PAC systems, they're calibrated, it's having to do it. We've got implantables, and interestingly enough, this one right here is what kind of kick-started it all, right? So we had these patient hackers that were diabetics, and they had plenty of time, and they had their insulin pumps, and they're like, I wonder what we can do with it. And then they started realizing that they could change the parameters that they put out. And this scared a lot of people. This scared me included. I'm there, right? What's that? So they could get into the software and change the operating parameters. So you could put in like 0.01 ml per hour, and they could, excuse me, on the individual machines. Yes, it wasn't. Yeah, this wasn't a global thing. But Barnaby Jack did it here in Las Vegas, right, on an infusion pump. We found out that he kind of modified the pump to show how it worked, but you know, it wasn't quite as pristine as he let us believe. But it scared us, and it scared the FDA into action. Right, here we are back to the Internet of Things, right? Anywhere, any place, anytime, any device, anything, right? And it's big. There's a lot of stuff here, right? This is $4.3 trillion is what we spend on healthcare, $12,914. And I don't know about all of you, I don't spend that much. So some people are like way up here. I've heard a statistic that said something like 5% of the patient population spends like 60% of the medical costs. It's pretty crazy, but it's 16.8% of our GDP, right? That's huge. That's a lot of money. That's a lot of money. It's like right up there with, not quite with defense, but it's pretty big, right? Here's a basic infusion pump system, right? How simple the network is, pretty clean, just has one firewall, one external connection, right? And some stuff going on the inside. Right, but the important thing is there's vendor access through the internet into our system, right? So if you think of all these spaces, right, here and there and there, they're all boundaries, and across those boundaries, transactions happen. We're sending ones and zeros, data, instructions, right, code, right, and those transactions are what we must protect. That's the real thing with cyber. Is protecting the transactions. Just like inside the box, we protect and control how fast the pump works, you know, all of the things that do the clinical functionality of it, right? But this is a fairly simple system. If we get into our diagnostic imaging, we not only increase the number of devices right? And where it goes, but the number of relationships that we have. So now we've added a whole bunch of new interactions, new boundaries that we have to cross and control, right? Very, very important to think about, right? And then when we get into telehealth and even the home environment, you know, this is kind of now the Wild West, right? It's just out there. The FDA has said, and they've told manufacturers, you cannot rely on two things for cybersecurity controls. You cannot rely on the environment, like distance from here to here, right? Many times you think of like your pacer pads where you have to be very close, right? You have to be that close in order to do it. You can't rely on that physical boundary, because guess what? Even, you know, low energy Bluetooth, right, with an amplifier and magnification of that signal, right? Amplification of that signal, I should say. You know, you can pick those up and impact them from a greater distance than that was designed for, right? So, and the other thing is you can't rely on human nature, right? So you can't say, well, they'll keep their apps updated. You know, we have a hard time doing that in hospital. You think we're going to get that done at home? No. So just remember that. And here we've got now, there's that telehealth platform that goes in there. So now we've got a third party involved in all of this, and we've got business layers, security layers, and infrastructure layers. So lots going on there. It just gets worse, right? So the healthcare matrix in the US, there's about 6,400 hospitals, and I don't think this includes the VA, right? The single largest healthcare system in the country, right? And we've got all kinds, just like Hollywood Presbyterian, we've got urban teaching and trauma centers, you know, deep in the urban centers. We've got, you know, suburban, right? The flight to the payers, right? No more pill hills. We went out to where the payers are, make it easy for them to get to. Community hospitals, rural and critical access, right? For those that don't know, right? 25 beds or less, 100 miles to the next healthcare provider, right? They get paid, right? They get PATA, they get reimbursed. Yeah. So they get paid, the federal government reimburses them. I think it's 1% above, or 2%, I'm sorry, 2% above reasonable expenses, not actually actual costs, reasonable expenses, right? Hard to make a living, hard to invest in yourself with that kind of margin, right? And then there's the thousands of these, the diagnostic and imaging centers, clinics, wellness, and physician practices, right? And there's thousands and thousands of these. You've got work for a large healthcare organization, right? And if you've got 10 hospitals, you've got probably 1,200 different relationships with various entities, right, of where it is. So I worked for a 100+ hospital system. That was Catholic Health Initiatives at the time, right? We had 380,000 medical devices, and this was everything because we managed it all, right? This was anesthesia carts. This was scopes, rigid, flexible, right? All the light sources right up through PET CTs, tympanic thermometers. So we had a pretty good handle on what we had. We knew we had a whole bunch that were connectable. We didn't know which ones were connected. When our CISO said, what do we know about medical devices and cybersecurity? The answer was not a damn thing, right? And this was 2014, right? So the nice thing was we figured out that we had about 100,000 that were connectable. We had 1,200 makes and models of these devices represented by 500 different manufacturers. And that is a daunting number. And that's probably what makes this the single hardest thing to do, because that defies categorization, right? You can't have, you know, the solution you put in place for your infusion pumps is not going to be the same solution that you put in place for your physiological monitors, your clinical diagnostics, your diagnostic imaging. But 20 manufacturers account for 80% of the device count, right? That sounds easy, right? But think about it. Infusion pumps, particularly if you're rationalized across that or standardized across that, infusion and physiological monitors, yes, I can say that, are the two most highest count devices in an acute care setting, right? Just easy to do. The FDA has 560 product codes for software-enabled medical devices, more than that, right? It's just, and this is, yes, there's 4 kinds of infusion pumps or 6 kinds of infusion pumps, and they each have their own product code, but that's what it is. It's a complex space to be in, hard to figure out, right? The FDA update, and I'm going to say this, you guys, yes, healthcare is not regulated by the FDA, right? And I hear this a lot that they are, but they're not, right? You're regulated by their pals at CMS through Joint Commission, or who's the folks down in Texas? DMV, yeah, exactly. Thank you. So, right, but the FDA was granted statutory authority over cybersecurity in December of 22. It didn't go into effect until March of 23 because of a 90-day delay, right? But Congress said, enough. We're going to give you statutory authority over cybersecurity. So now they can look at this, and they can look at cybersecurity alone, not just the safety aspect of it, right? Because they know cybersecurity is patient safety, right? So the omnibus appropriation bills, big thing, I think it's like 17 point something trillion dollars, right? The FDA got $5 million for some new staff, not that much, but they got the authority to go ahead. And they've been saying this for years, right? Now they just had the stick to go along with the instructions, right? Effective for that, but only for new submissions. So that doesn't cover your 19-year-old system, right? Sorry to say, right? Doesn't do it. So the omnibus bill, and this is what pre-market guidance had, right? And I just stacked this up. This is just to leave behind. You guys can look at this. Don't take a picture. You can get it all, right? You can take a picture if you want, sorry. But it just shows the alignment between the two, right? So there's a lot of people working on this for a very long time, for several years before they came out with this. So it's good space. It's good stuff to see, right? Here's what I really think, right? It's quality system regulations, right? They put it in the quality system. So what they said was, if your medical device could be made to do something that you did not intend it to do, that's a quality issue and you need to fix it, which is brilliant. It's a brilliant approach, except for one thing, right? Quality means regulatory affairs on the manufacturer side. Regulatory affairs says, just like when the Joint Commission walks in the door, what do you guys do, right? Right? You don't ask, you don't answer a question that's not asked. You don't give them a piece of paper they didn't ask for, right? This is regulatory affairs in the manufacturing space. Exactly the same principle, right? So you get it, you understand it, right? Cybersecurity is patient safety. Very important concept there. Secure product development framework, meaning you've got to build cyber in from the front. You can't bolt it on the back end, right? So this is going to be refreshing. It's going to help, but it's going to take us a while to get there because we got a lot of stuff, right? Security objectives drive security requirements and security controls, right? And that's a lot to say, right? And I've got a better slide for it, right? Cybersecurity, transparency, and labeling. This is the SBOM. Anybody heard of an SBOM? Right, a few people. Software bill of materials. Think Campbell's soup, list of ingredients, right? That's what it is. My device here is made up of this list of software components, right? That's what's in there. So now when the next log4j comes out, we should be able to go, oh, you know, that log4j exists in 34% of my medical devices. And that's represented by 160 manufacturers. And that's 160 manufacturers I got to reach out to, not all 500 of them, right? So it should help us. Transparency and labeling, security risk management, threat modeling. This is the real thing. And I think this is key because everybody talks about risk assessments, right? And I think threat modeling, what can go wrong? Threat modeling is what can go wrong, right? And what happens when it does. And that's the real thing, because it's really talking about impacts. This goes back to how we manage the environment of care, right? We know that fires can start, right? We know that we can have gas leaking out of places. It's like, what happens to our ability to deliver healthcare when we get there? And IT doesn't think like that. They're chasing vulnerabilities, like swatting flies, right? So I think the threat modeling is a interesting piece, right? And then they're like cybersecurity testing. So when people put in submissions, they're going to say, your threat model says there's these kinds of risks, right? You applied these kinds of controls. Show me the testing that shows me that those controls were effective in managing the risks you identified. So all that ties together. This is risk management 101, right? Here's that secure product, and this is security objectives and the requirements, right? So I'm not going to read all of this. It's the basic stuff, but this is authenticity. Do I know who you are, right? Authorization, right? What can I let you do once I let you in, right? That's authorization. Availability. This is the important part, and this is the impact that we're seeing ransomware have on healthcare, is all of a sudden the stuff we need to do patient care isn't available, right? Isn't there to do it, right? Confidentiality is really about protecting the identity of things, whether it's patients, staff, all of that stuff. I think HIPAA is the worst rule we ever had, right? It was necessary, right? Back in the 70s, we had to protect healthcare from healthcare because quite frankly, we were crap at managing other people's data. We've gotten a lot better about it, right? But now we treat HIPAA information, which is also just sensitive information, like my social security number is sensitive information until I attach it to a diagnostic label, and now it's HIPAA, and I treat it all kinds of different. I think we should just all call it all sensitive information and treat it uniformly like the rest of the world does. Okay, but I'll get off that soapbox here. But anyways, and then secure and timely, updatable, and patchability, right? So I know you guys are all frustrated. I'm frustrated, and I say guys, I mean gals as well, right? The fact is, we know there's a lot that's wrong with our medical devices. There's a lot that can get patched, right? And it just doesn't come out. We wait for manufacturers to go, oh, here's your update, and they don't give it to us. It's frustrating. It's frustrating. It's frustrating to the point that when we do get them, we don't do a lot with them, right? That's how bad it is, and we need to fix that. And here's one. This one gets me every time, right? In 2019, a woman went in for a scheduled birth, right? An induced birth, right? And they were 8 days into an attack. They didn't tell her, right? Because this impacted the fetal monitoring system, they did not have centralized fetal monitoring, and they did not have adequate staffing to have somebody in every single room, right? Now, they had an umbilical wrap by the time it was detected, right? And they went in and did an emergency C-section, you know, and the fetus was resuscitated, right, after birth, right, and survived about 9 months, right? Totally sad, totally unnecessary. But I bring this up for 2 points. We become dependent on the technology that we're given to the point when it goes away, it puts us at risk, right? If your anti-lock brakes didn't work in your car, right, you're not stopping as quick as you thought you could, you know, things like that. So it puts us at risk. And here's the really sad thing about this whole thing. These two, this is what was exploited by this Ryuk ransomware, right? Completely patchable, and completely patchable on the systems that were ransomed, at least for the TOCO systems. So had those updates been applied, this system would not have been susceptible to this, and this incident would not have occurred, right? And that's the sad thing. And I make that point. Yes, sir. The central stations, not even the central stations, the servers that fed the information back up to the central stations. Yes. Yep. They were. Yeah, they were. Yeah, that was the sad thing about this. That's what I said. That was the sad thing. The system and the manufacturer would have put those patches in place, right? So again, that's what I say, the frustration that we have with the patching cycle, even when they're available, sometimes we're not doing them, right? Because we're so frustrated with the whole process. But this was a preventable accident, right? Preventable incident, right? So, and this happened in 2019, and I cannot find an update on this. I wish I could update this line, but I cannot find anything. So I think there was a settlement, and it's been hush hush, and nobody talks about it, right? But I can't find what really was the outcome here. So complex life cycle, right? There's a breadth of technology. We talked about all this, legacy devices. This is something that Health-ISAC came up with years ago about managing the life cycle. And we've got manufacturers, the suppliers for manufacturers, right? And then the medical device manufacturer, all the processes they go through, right? And then the manufacturer maintenance. So who works well? Who's in biomed and really works well with their IT team in the hospital? Right? Just a couple of you, right? Right? Otherwise it's this, or sometimes it's, you know, I don't even buy that guy pizza, you know? So what I find at manufacturers, we got product development teams, then we have service teams, and I talk to service teams about cybersecurity, and they're like, what's that? They have no idea. So that dysfunction that is in healthcare happens in other places as well, right? So, and then there's the once it's in the hospital inventory, right? What goes on there? So cybersecurity program, that's what we're talking about. What time is it? How much time do I have? Where's my room moderator? 4:36. All right, so I got plenty of time. Good, good. So I don't want to, I'm not going to run you guys over. I know you got other things on your mind. So who recognizes this? Right? This is just a regular life cycle of how we manage stuff, right? This is it. This could be your MEMP, right? Secure procurement. What are we going to do to maintain it? What are we going to monitor? How are we going to respond to it? What about disposal? That's it, right? And this is why I say, right, for HTM staff, this is all, you guys are familiar with all this, right? This is no different. We're not doing rocket science just because we're called IT, right? Here's the thing, right? Cybersecurity is just a failure mode. It's a way for stuff not to work when you want it to. That's all it is. And we have to start thinking about it that way and planning for it that way. Okay, so it's an important element to this, right? And our job as HTM is to keep this stuff running, right? So do I care whether the platter on the hard drive for my MRI station just goes corrupt or whether it gets ransomed? The thing is, what am I going to do about it when it happens, right? The cause of it, the thing that cyber inserts is an element of intent, right? That's the scary thing for everybody because you can't like engineer or predictively engineer for that, right? It's not like how many cycles will this filter work, you know? How many cycles will this fan turn for? How many cycles will this happen for before we have to replace it, right? Like changing the oil on your car or the tranny fluid, right? You do that ahead of time so that these things don't break down. If somebody takes and puts salt in or sugar in your gas tank, you know, all the oil change in the world isn't going to save your engine, right? So it's the intent part that makes the cyber side really scary for us. But we have to think about it just if it fails. So think, right? If the CT pops, if the CT tube pops, you know who you're getting the tube from, how long it's going to take to land on your loading dock, how long it's going to take to install it and calibrate it, and when you can return that system to use, right? And when that tube goes out, you could tell the radiology director when they can expect to have their system back if all things work as expected, right? And chances are, because you're a good technician, you noticed it spitting a little bit ahead of time and you had one pre-staged and already on its way or sitting on a loading dock for it anyway, because you've got that kind of relationship with your maintenance provider, right? So those are the kinds of things we have to start putting that cycle into. What happens if I lose my platter, right? What happens if I lose my hard drive? What am I going to do about that, right? Where am I going to get it? Who's going to rebuild it? Am I going to just stick in a new hard drive that took 2 weeks for my OEM to get to me, right? And then rebuild from disk, right? Or am I going to have thought about this ahead of time, ghosted that hard drive, right? Wiped all the PHI off of it, re-ghosted it. So now I have a pristine drive, right? And then when it goes out 6 months later or 8 months later, I stick that drive in, I do a couple months worth of updates and I'm back up and running in 4 hours and not 4 weeks, right? And oh, by the way, I can then take that ransom drive and hand it to my IT team so they can run their forensics on it, right? So they get their job done and we can get back to the business of taking care of patients. That's how we have to start thinking about this. And that's what I'm really encouraging you all to start thinking about, right? So this is it. This is a biomed thing right here, right? You know how I can tell? Because they got the water pitcher right next to the electronics. But HTM, job one, it's maintenance operations. How do we keep this stuff up and running? That's our job. That's what we do day in and day out, and we do it like firefighters, and we're freaking good at it, right? So take pride in that and just start thinking, expand my horizon. How can I expand my horizon into the IT world? Does it mean I need to know everything about IT? Not at all. right? How many different specialties do biomeds have? You got a guy for the lab. You got a guy for surgical services. You got a team for imaging. And oh yeah, there's the ultrasound person, right? And then there's the MRI and the high end, the big iron person. Then there's the one that does linear accelerators because they're working in that magic world all by themselves, right? You've got patient monitors. So we've got all these specialties, and IT does too, right? We just don't understand them, but they do, right? And the real thing is this: when we talk about when we talk about biomed stuff, it's a one-to-one relationship, one machine, one patient, one test at a time, right? That's a one-to-one-to-one. IT, it's one to many, right? And that's a different culture, and they operate differently, and they need to, right? Think about, somebody mentioned it in the last, right? The NotPetya thing that hit Merck, right? It wasn't intentional. Somebody just hit a switch. It wasn't even intentional, right? 6 minutes later, 40,000 endpoints were infected with NotPetya, right? That's the one-to-many that IT has to deal with. So no wonder nobody wants to take responsibility. No wonder they want to gather the clan and have a powwow before any decisions are made. It's a slow process because it's a big impact, right? And that's tough for us to understand, but if we understand it, we can work with them better, right? And that's all I ask you to do, right? So anticipate and respond. That's what we do day in and day out, right? Somebody said, oh, hey, what happens when IT gets a call? And they're like, well, let me turn it over to an analyst to see what they do. And if they don't like it, they'll turn it up to the next analyst too, to see if they can fix it. And maybe in a week or two, and we'll get back to you, you know. And when they call the biomed shop, what happens, right? Hello? Yeah, I'll be right up. I'm on my way, right? It's just a different thought process we go through, right? So take advantage of it, work, right? Just know your IT counterparts, figure out who you got to go. Governance is all about who makes what decisions. It's easy, right? You all live at home, you all have a spouse or a significant other, right? And who makes what decisions, right? That's what governance is, right? Who writes the checks? What are we paying for? Are we buying a new car? No, we're not. That's governance, right? That's all it is. It's not that complex, right? We give it a good word. We have all kinds of things around it, right? But it's really like who makes what decisions? What are we doing? And this, right? Your medical equipment management plan, right? MEMP. We got to do the same thing for the cyber side of it, right? What do we need for inventories? Now, remember I said the SBOMs? Now you've got, instead of one asset ID, you're going to have a whole bunch of components that go into that, right? It's tough. Program performance. How do we know we're doing good, right? What are we measuring? How do we know we're effective? How do we know we're good at what we're doing? Equipment maintenance program. How do we keep this stuff up and running? What's our thing? What are we going to do when things go wrong, right? And then how do we respond to product notices and recalls? And I'm meeting with the FDA and CISA actually right now because they're not treating cybersecurity disclosures from manufacturers the same way that they're treating alerts and recalls, which we've been doing since the mid 70s, and we're damn fine with it and very comfortable with it. And I wish they would just like get on board and follow that model because it works. It works in healthcare, right? But we'll figure that out. Risk management. It really comes down to this, right? Biomeds, HTM, clinical engineers, whatever you want to call yourself, right? You guys keep it running, IT keeps it talking, right? That's their job. Work with them, right? They're the communications people. We're the operations team, right? Together, we're pretty good at what we do. Safety changes can impact security. That's what this Venn diagram is about. And security changes can impact safety, right? So it's a slower process. It takes a little while. Understand that, work with it, be comfortable with it, right? Cyber is not just failure, there's intent behind it. I mentioned that before, right? And this is probably the most important thing that you guys have to understand, right? We have a lot of legacy devices in our healthcare system, right? A lot of old stuff. It was installed before we even knew how to spell cybersecurity, right? And we're still installing it because manufacturers aren't selling better, right? I mean, I can still get a Windows 10 system today, right? Chances are if I buy a new medical device, it's coming with Windows 10 on it if it's a complex box, right? And that's out of support already, right? Went out of support last January. So But my point is, we can't fix it all at once, right? So what you have to do is get your business owners, your clinical leaders, like, what's most important to you, and let's take care of that first, right? That's really the key here, is being able to parse it out and get it in pieces that are manageable, right? Whether it's types of equipment, whether it's, whatever we can do, we've got to make it manageable, right? And tolerable and palatable. And most of all, we've got to make it affordable. So we can't do it all at once. We've got how many billions of dollars in medical devices in our inventory? There's no way we could do it. We used to have an equipment planning group, and we would go in and do we call it a technology assessment. We'd do an attic to basement assessment of every piece of patient care equipment, right? And we did it based on factors like serviceability, failure, cost of repair, clinical preferences, but we tried to take all the new shiny out of those conversations and give administration, like, here's a 3-year spend on what you need to do to not only keep your lights on, but also, step into the service lines that you're anticipating stepping into, right? We give them a 3-year spend. They couldn't spend a third of what we were telling them for any given year. They didn't have the kind of capital, right? That's how old some of this tech debt was, right? But it knew that if they had to make a decision and I had to get a replacement here, they knew what was getting pushed down the ladder, right? So it was an informative thing, and it was very helpful. And that's why I say the business owners have to be involved. They know what it takes to deliver patient care in their clinical department. And it's different. You can have the same CT supporting your ER that supports your suburban imaging center, right? Same make and model, maybe a few different clinical apps on it, right? But basically the same device. And if you ask the clinical leaders, what's more valuable, this or that, and they'll give you different answers. And it's right. It should be right. You can't just say this model everywhere in our system has the same impact on patient care. It doesn't, right? Healthcare is one of those funny things. We operate more like a mall full of specialty stores. It's like we all sell clothing. Somebody sells belts, somebody has pants, somebody has shirts, right? We're kind of related. We kind of do the same thing, but we run our businesses differently, and hospitals operate that way, right? Even though there's a trail, what do they call it? The patient care, what's the Joint Commission calls it? The environment of care, but what are they? The tracer analysis, right? They take a patient and run it. They trace them through each department, right? And they make sure that each department gives them good outcomes, right? And but they're handing it off. And the reason they do that is because they know that there's a department that doesn't get it, right? That doesn't do their job, and that interrupts the quality of care on the outcome, right? So asset management, right? We'll look at install base, right? We do incoming inspections. We've got asset IDs. If we're lucky, we've got our RFIDs, right? And we can tell where our stuff is. We focus on make, model, and sometimes version, right? And now we've got nice passive scanning tools, and these have gotten really good, right? Back in 2017, when they were brand new, they couldn't identify 10% of the stuff they saw on the end of the wire. Now it's probably 10% that they can identify and classify correctly. So they've come a long way, and they've gotten better. IT, they're completely different, right? They're standards compliant, right? We've got these standards, you got to comply to it, right? I had to go through our security standards, and there were 21 of them, and I had to medicalize them. I had to go through and say, look, you've got 30% of your endpoints cannot comply with the standards that you just created. So let's write standards that you can actually accommodate, right? So you don't get yourself in trouble, because we can't afford to replace, 80,000 medical devices, right? They focus on IP address and MAC addresses. They're looking at OS and patch levels. They do vulnerability scanning, right? We do uptime requirements, right? Is the equipment available when we need to use it? That's a key measurement, right? And it's absolutely correct. And they're doing SLA response times, right? What happens when you call IT and you ask them about a work order you opened last week? They open and close another work order, because their response time, their SLA is how quickly can I open and close work orders, right? And we get these unintended consequences that are culturally different. So I have this because this is the line of friction right here between the two, right? It's just the different cultures, right? Secure procurement, and we have to think about this, right? Secure procurement is nothing more than evaluating for fit through multiple stakeholder lenses, right? And this is important, right? There's the clinical benefits. Are we gonna get better procedures, better outcomes, right? Are we gonna be able to do things we can't do today? Finance, right? Are we increasing our revenues or decreasing our costs, right? Is there a monetary impact? Serviceability, this is what clinical engineering looks at, right? How am I gonna maintain this thing through its life cycle, right? Throughout its life, right? And almost like full service, and I'll get some training, and then I'll do, you know, some service assist on it, and eventually I'll step into it, and then the manufacturer won't do it, and I'll keep it running with baling wire and bubble gum for the next 15 years, right? That's how we do it. And risk management, is it safe to use? Is it secure to operate? And is it future safe, right? So can we keep it up? And this is important. So procurement is an important cycle in here. And too often what we see is like IT is like, oh, that doesn't comply with our standards. You can't have that device, right? And they don't think about what are the clinical benefits to the business that we're actually running, right? So we have to think about it. So they shouldn't be showstoppers, but they should inform the decision, right? They should inform the decision all the way down the line, right? Legacy equipment, right? AHA, you were mentioning this, 7 to 12 years is the most common life cycle in there. And I've been asking the AHA to go through this and update it for the IT enabled devices, right? Because they haven't. This is based on sterilizers that 20 years ago, and they're still saying they're 12 to 15 years of sterilizer use. They haven't really updated it. The OS out of support, manufacturer no longer supports it, right? How good are we with baling wire and bubble gum, right? It's clinically useful. It still does the job we bought it for 7, 8, 12 years ago. It's still working fine, lasts a long time, right? Or how many times has this happened? We got to get a new med camera because this one's old, you know? And so we get a new one and they're like, oh, Dr. Smith likes that and it's a good backup. So we keep that one. Now we've got 2 systems to maintain and pay for, right? So at the end of life though, think about this. We do a risk assessment when the device walks in the door. How good are we about assessing the risk at life cycle thresholds, right? It goes end of support. You go, oh, what's the risk of this, right? You begin thinking about it. And I know y'all do. It's like, how expensive is it to maintain? Will I be able to still get a service contract on it? Can my guys get skilled up enough to maintain it, right? All of those questions, we start doing that. So what are the support costs? What do we got to do for capital planning? We start getting it on the radar, right? We should have, and this is a risk, this is a cyber risk thing, but it should be just a risk thing, right? There should be a threshold that says this device is no longer tolerable for use in this organization. What is our risk? What's our pain threshold? And when it hits that, whether it's service cost or just overall cyber risk of the device or risk of the device, we should be like, no, we're not doing this anymore, right? So we've got to start thinking about this and working this into that conversation, right? And we've got some tools for that, right? Not here though, on this screen, right? Maintenance. This is what we do. CMS is we do work orders, right? And CMDB, they do tickets, right? Same thing, you know, potato to potato, right? It's really the same thing, but we're working on uptime requirements. You know, is the device available when we need it? And they're working on, can I close the work order within 2 seconds, right? 5 seconds? Oh, 5 minutes, thanks. All right, I'll be quick, appreciate that, right? This is an important element here too, right? This one right here, this correlation is essential. How many different asset management systems do you have? How many folks have like RTLS in there, right? You've got RTLS, that's got one ID. You've got your CMMS, that's got a different ID. You've got your ServiceNow, right? That's got a different ID. Same device, different IDs, different people maintaining different aspects of equipment, right? All doing their job. You've got to be able to correlate it so that you know Chair A is his Chair 3, is her Chair Zeta, you know? So we've got to be able to do that. The correlation is the hard part there. It takes discipline to do that as an organization, okay? Anybody familiar with RACI? You like RACI?
We just did on ICM, we actually did a talk on RACI to inform biomed techs as well as anyone else out there how to use it effectively when collaborating with your IT counterpart. Just so you know who's responsible for what. Yeah, love it. Great tool ever.
Good for you. I applaud you. I applaud you. Yeah, this is great. This is responsible, accountable, right? Consulted and informed. The responsibles are the doers. There can only be one per task, right? You can only have one doer. Accountable, you can only have one person accountable, one decision maker, right? And it's different for the different things. We would do these, we would start at like imaging, right? We would say, here's diagnostic imaging, and we'd have a RACI for our entire company. And then when we did incoming inspections, we'd be like, oh, who's got skills in this location to take care of these elements, right? And then we would assign them from that. But because we had a base model, it started to look the same, right? Based on the capacities and the competencies that we had at each location, you know, for that particular make and model. But this is a very useful tool. IT uses it a lot. They love it. You know, adopt this, go for it, right? Go for it. So monitoring, we've been getting better about this. Remember I mentioned that passive monitoring tools, much better with monitoring, and I've got to scoot over this, right? But the important thing here, right, is really calm traffic patterns, right? What the devices talk to and what talks to your devices. And then just as importantly, being able to flag when things are talking to things they shouldn't be, that we don't expect them to, or out of band. We don't expect this much traffic to go through the firewall to this location, right? I once had a CISO said I was bleeding, you know, 2 gigabits a second out of my wire, and I'm like, did you turn it off? And he's like, no, I didn't want to interrupt patient care. I'm like, there's not a chance in hell, right, that had anything to do with patient care. Somebody was stealing your data blind. That's all there is to it. But you have to think about that. You have to think about what can happen, right? And then what are we going to do about it? You know, you can't think about where's the fire, where's the water bucket, the fire starts. You want to know bucket is before. So start thinking about how things can go wrong and what we're going to do about it. And do this with your IT team, right? So they're just as informed. Response. This is what we do. Here are here's the impact stuff that we talk about, right? So when you're doing those risk assessments, right, think about patient safety and staff safety, right? They go hand in glove. We're good at that, right? PHI and big PHI. Anybody know the difference? Big PHI, 500 records or more. Why is that important? If you lose 500 records, it's an automatically publicly notifiable HHS breach, right? You're going to the paper, it's going to go on the wall of shame, you know, so it's big data, right? Big PHI is what I call it, right? Operational interruption, and this is important, right? Because the same device, you can lose that CT out in the suburban imaging center, right? And be like, oh, that's down for 3 days. And you're like, yeah, we'll just send them a few miles up the road to the other imaging center and they'll get their studies done, right? Or we can put them off because it's not urgent, right? Not a big deal. You lose that CT that supports your trauma center. Now you're on divert. You're losing 16 to 18% of your patients that come in through your ER during that divert period, which is a big hit on your revenue stream, right? So it's there. And then revenue, reputation, and this should prioritize everything. This kind of thing. It's the impact on the organization, not the vulnerability assessment, that CVSS score. It's like swatting flies, right? And what happens when you kill a fly? 10 more show up to its funeral, right? All right. And then IT has this RTO, RPO, right? This is like, when can we get it back to service, right? That's what we care about as biomeds, right? So recovery time and recovery point, I think the difference is like the degree of getting it back in, right? Like I can be 80% recovered. I think that's a recovery time option. Somebody in IT correct me if I'm incorrect. And then the RPO is like, when do we get it full back up the service? It might be the other way around. Disposal, and this is a 51 Ford F100. First year they built the F100 series. They moved from F1 to F100. And I used to own one of these, which is why I love this picture, right? But disposal, right? Drivers, final failure, right? Planned replacement, end of support, or we repurpose it, right? And where it's, I see people here that are in big organizations. You send stuff downstream, you still got to clean out that PHI before you release that, right? Requirements, remove organizational risks, right? PHI, credentials, configurations, right? Just like when we figured out back in the 70s that when we were swapping out Canon for Hitachi copiers, and every scan, every print job that we sent was sitting on the hard drive that we were just handing to somebody. You know, we've got to think about our medical devices the same way, right? that we've got to get rid of that. And you should plan for disposal while you're onboarding. How am I going to get rid of stuff, right? You bring in a new Pixa system, they all have an extra drive slot on them, stick in another drive, have them push all of the patient data, all of the drug libraries to that drive and not on the one that has the OS and the clinical app, right? Keep them separate. That way you can pull it out, turn them back in at the end of the lease and you don't lose any data, right? Cost you a couple $100 more, but hey, it's worth it, right? Because these are big organizational risks. So you got this, right? Understand the risk, consistent prioritization based on impacts, right? Understand the business owns the risk, right? So this is a clinical leader decision. Partner with your clinical leaders about this, right? And it's a team sport, you can't do it. So I'm gonna ask all of you to do just one thing, right? Go back, find a clinical leader, your favorite one, right? And say, hey, if you were to lose a piece of equipment in this department for 4 to 5 days, which one would hurt you the most? And then sit down with that leader, sit down with IT and yourself and think about how can this device fail and what are we going to do when it does, right? And build a response plan and just start with one device, right? It will teach you who the teammates in your organization are, how your organization works around this and how you can think about this. And if you do it with one, it gets easier on the next one and the next one. And pretty soon you've got a whole thing and you've got races for all of your different modalities and all of your different makes and models, and you're done with all of this, right? So that's the one ask that I do. Just take this back. It's an easy ask, right? Some of you guys have already done it because you've seen this before, right? But again, this life cycle, procurement life cycle, that's what we do day in and out. Here's the other thing. You want to know more? ISC squared, International Information Security System Security Certification Consortium. They've got a free program called in Cybersecurity, right? You can take this course for free, right? And it costs you $200 if you want the certification. You can get the certification for free? Yeah.
Get on it.
Yeah, right here, is2.org, right there, certified in cybersecurity, right? Get it. If nothing else, right? If you're a leader, this will give you the language to talk to IT intelligently about the way that things that concern them, you know. And if you're a young person that's got to get into this, this is a good way to get that vocabulary and start thinking about how IT thinks about the world, right? It's a great thing.